Welcome and good evening, everybody. My name is Stefan Stättner. Together with Stefano Partelli, we would like to welcome you on this evening to our ESSO webinar on pancreatic neuroendocrine tumors. We are very thankful that this webinar is sponsored by ITM, a strong partner for us. Let me please introduce our society. First of all, the European Society of Surgical Oncology is a big society with over 4,500 members across Europe and the world. And our major goal is to bring education to everyone, high-level education. And in the moment, I'm the chair of our education and training committee. Stefano Partelli is one of our big names and members, and he's mainly covering neuroendocrine disease. So ESSO is offering lots of benefits for you. Please have a look at the website. And what we do is we run a lot of courses. These were just the courses we've run so far till October 2024, 13 in-person courses with more than 600 delegates, and lots of countries taking part, and it's always great fun. And of course, we also present a lot of webinars and online educational courses as well. So please, if you're interested, because neuroendocrine tumors is one of our major topics as well, we collaborate with other big societies and also across the Atlantic Ocean, as you can see in our program today. So it is very important for us to deliver best knowledge and up-to-date knowledge to you. So now I hand over to my friend, co-chair, Professor Partelli.
Thank you, Stefan. Good evening, everyone. It's a great pleasure for me to co-chair this webinar. This is another webinar on neuroendocrine tumors. So I want to thank ESSO and ITM for giving the opportunity to expand the knowledge of these tumors in the surgical community. The topic this evening is trying to emphasize the importance of a multidisciplinary approach to these tumors. And so the surgeon should not be alone in the decision, especially in patients with advanced disease. We know that surgery can play an important role also in the presence of metastasis, but it's crucial to manage this patient in a multidisciplinary setting. And to discuss about this, we have an impressive faculty this evening that include them among the main specialists of neuroendocrine tumors. So we have two oncologists who are also the presidents of the most important society in the field of neuroendocrine tumor, the European Neuroendocrine Tumor Society and North American Neuroendocrine Tumor Society. So Dr. Nicola Fazio and Dr. Thor Atherson. And we have two surgeons, one young surgeon who is Valentina Andreasi, who is a resident work here in Milan with our group, who will present a case. And among this case, we will discuss with another prominent surgeon, who is Professor Julie Allett from Toronto, and one of the most expert nuclear physician in the field, that is Professor Valentina Ambrosini from Bologna. So the agenda is very busy, so I would like to start by introducing the first speaker, who is Dr. Nicola Fazio. Dr. Fazio is the head of the digestive oncology in the European Oncology Institute here in Milan, and is also, as I said, the elect president of the European Neuroendocrine Tumor Society. Nicola will start with stressing the importance of the multidisciplinary approach, and is one of the most supportive clinicians of this approach. So please, Nicola, the floor is yours.
Thank you so much, Stefano and Stefan. It's a great pleasure for me to be here in this very nice and expert context. Thanks for involving me. I will share my slides. Can you see my slides?
Yes.
Okay, perfect. So, multidisciplinary collaboration, just to introduce this meeting. First of all, this is an example of what the prognosis of patients can be improved when patients are managed within a multidisciplinary context. This is a slide presented by Matthew Kulke years ago at an ASCO meeting, and he remarked that the median overall survival of patients with pancreatic NET were threefold higher in a NET referral center, the Dana-Farber in this case, compared with the SEER database, the SEER registry. And also ENETS, the European Society of Neuroendocrine Tumors, decided in 2008 to start to set up an accreditation and certification program which allowed applying centers to be evaluated on several contexts. But first of all, these were the requirements, but one of the major requirements was the multidisciplinary team. And ENETS started in 2009 with 6 centers, pilot centers, and in 2010, the official process of certification was launched. Now, as of March of 2024, we have 69 centers all over the Europe, but not only Europe, as you can see here, certified for gastroenteropancreatic neuroendocrine neoplasms. And for some years, we are also certifying centers for pulmonary NETs. Now we have 15 centers certified. The auditors are known expert ENETS expert auditors, and also DQS, that is the external certifying society. So why it's important, the multidisciplinary in pancreatic NET? If we consider a patient with an advanced pancreatic NET with somatostatin receptor positive imaging, we have these 5 therapies that all of them are available in our hands and in our clinical practice. All of them were approved in this context, but they are so different each other: SSA, everolimus, sunitinib, PRRT, and chemotherapy, and even different types of chemotherapy. Of course, this is a good news to some extent, but this is also an embarrassing context, as we don't know who is the winner between this therapy. And the situation is even more difficult if we consider that also locoregional surgical and non-surgical treatments can be proposed and utilized in the same context. So this is quite a challenging clinical context. And this is a challenging context due to some critical aspects. First of all, we are not sure to have a real predictive factors for efficacy of to all these therapies. Second, we never validated criteria of priority about these treatments. And finally, all these treatments were approved on the basis of a PFS, improved PFS, but not significantly improved OS. So it's difficult to have in mind upfront a priority about one of these therapies. Therefore, the multidisciplinary context is crucial in PANNET, advanced PANNET. When this is crucial particularly? It's crucial to share the therapeutic strategy, as of course we should define a therapeutic strategy rather than to choose a single therapy. Second, to contextualize some controversial factors. You know, for example, that the FDG, PET-CT, or some other factor like MGMT to predict the response to some chemotherapy alkylating agents. They are not so well validated predictive factors, but they are commonly used in clinical practice. Even Ki67 doesn't have an absolute value. So if one of these factors is utilized by the single specialist, it could be even dangerous, as of course the choice is based on the personal view of the single specialist. Therefore, in this case, it's crucial that these factors are put in the context, the general context of all the information that are useful for decision making. Third, MDT is also crucial to optimize the global treatment, but in other words, MDT is crucial to personalize the treatment. This is the key word in my opinion. So personalization of treatment in PANET patients. All of us know that there are several general factors that can change radically the decision making. For example, tumor morphology. No, it's completely different to approach to a well-differentiated net compared with a poorly differentiated one, or the presence or not of the clinical syndrome. And even, of course, the SSTR2 functional expression, so the gallium PET positive or negative. All of this can change drastically the therapeutic decision from the beginning. But, of course, this is the starting point. After this, you have to decide. For example, in this case, we have the three information. This is a pancreatic net, metastatic, no syndrome, and the Ki67 is G2 low. But you can see that, of course, we have to consider the clinical condition of the patient. In this case, the patient is a sporadic net, slight symptoms, good performance status, and also the quite high tumor burden, as you can see in the liver, but very good uptake of the gallium PET. Okay, so we are considering more factors that should be discussed in the context of the MDT. And what is the main point? What is what are the main criteria to decide what is the priority? Do we have predictive factors? For example, SSTR could be considered a predictive factors. In this case, for example, there is a very high uptake at the gallium PET, so one can think that PRRT should be proposed upfront, for example. Or evidence. Do we have evidence that can give us an answer regarding the sequence of these therapies? Or should we check the guidelines? Or should we consider some more clinical factors? For example, let's give a look. Let's have a look at some guidelines. The ESMO guidelines consider the Ki67 with a sort of an absolute value, 10%, lower than 10%. In this case, SSA should be preferred. More than 10%, you should start with different therapies. The INETS guidelines, yes, consider again Ki67 10%, but not so drastically, as they report some clinical context. If you have an asymptomatic patient and or stable or slowly growing disease, you should start with an SSA, preferably if the tumor is less than 10% of Ki67. But if you have a symptomatic patient with and or a fast-growing tumor, you should start even with chemotherapy. But some more clinical factors can be useful for us to arrive to a right decision. For example, are the metastases limited to the liver, or do we have also extrahepatic metastases? What is the tumor load? What is the site of the primary tumor load? In that case, for example, it was the tail of the pancreas. Is it resectable? So we should ask a surgeon upfront an opinion about the resectability, and should we use some more factor for example, FDG PET? So all of this information can be useful to arrive to the right decision making, of course, if they will be discussed within a net dedicated multidisciplinary team. This is the other aspect of the MDT. The MDT shouldn't be only a very good multidisciplinary context of several very good specialists, but it should be dedicated to the pathology, should be dedicated to net. All these specialists should speak the same language, should interact each other continuously. So, for example, the MDT could be useful also to optimize the use of the PRRT, as of course, this could be an hypothetical ideal flow of the patient to arrive to the PRRT. The gallium PET should be performed as soon as possible in NET. The feasibility of a PRRT should be decided by the nuclear medicine expert when it's possible, as soon as possible. And you know that they have to discuss some aspects, for example, match and mismatch of the functional tracers like FDG and gallium-68. But also the indication of PRRT should be discussed within the MDT, and the indication is not up to the nuclear medicine expert only, but the indication is a collegial decision of the group. And finally, what is the right timing of the PRRT after decided about the indication? So just for that, all these steps should be shared within a net dedicated MDT. For example, if you have such a context, no, in this case, you have a perfect concordance between morphological and functional imagings, and you have also an homogeneous gallium-68 uptake. So it's quite simple to decide about the feasibility of PRRT, but in this case, you have a clear mismatch between the gallium PET here and the FDG PET here. So what is the right decision here? Is the PRRT feasible? Yes, but is it indicated? Who knows? So it should be discussed within the MDT. This is the crucial importance of the MDT. Another aspect of the MDT is that the goal of the treatment can change completely the sequence of therapies that we will arrive to decide, or our therapeutical strategy. For example, if you have in mind the tumor growth control over time, and so the maintenance of the quality of life, you could on a systemic therapies sequence. But if you would like to get a debulking, for example, you should perform a cytoreduction. So in this case, in the same patient, the clinical therapeutic strategy can change completely. For example, in this case, you could choose one of the two strategies, no, at the same time. But if this disease is judged as a potential resectable in the future, you could decide a combined strategy, surgical and medical strategy, starting with submedical therapy and performing several surgical steps to arrive possibly to an absolute debulking. Of course, this is a therapeutical strategy that should be discussed within an MDT. And sometimes you could even start with an upfront PRRT, as Stefano very well published recently, for example, in a context where the disease is potentially resectable even upfront, but there are some high-risk factors, even some oligometastatic condition, for example. And in this case, you could even decide not to wait for the progression to the SSA, but to start upfront with an PRRT, arriving to a radical surgery without a worsening morbidity of the surgical approach. All these are examples of the crucial importance of the MDT. Therefore, to conclude, we could say that personalization of the treatment is needed for all PANET patients. And the therapeutic sequence or integration or combination in the advanced PANET depend on several factors, mostly clinical, I would say, including the goal of treatment. Therefore, a non-dedicated multidisciplinary team is crucial to arrive to the best personalization and, of course, to improve the prognosis of patients. Thank you so much for your kind attention.
Thank you. Thank you very much, Nicola, for your great presentation, also because you clearly demonstrated how it's difficult to manage this patient, how similar situations can be very different, especially from a surgical perspective, of course, that we are not so experts in all these treatments. So we move on with the next talk, and so it's my pleasure to introduce Dr. Andreasi, Valentina Andreasi, who will present a very complex case, I would say, in which we tried to put together all the efforts and all these specialties for this patient. I think that, Valentina, you can start for the questions. Maybe we can do all the questions at the end of all the talks. So please, Valentina.
Okay. Good evening, and thank you for the introduction. It is a great pleasure for me to have been involved in this webinar. So just a second. Okay. So I'm going to present the case of a female patient who was aged 75 at the time of diagnosis, non-smoker, non-drinker with a normal BMI. In her past medical history, she had a previous breast carcinoma in 2003. And the present medical history starts in July 2019, when, after the onset of steatorrhea and development of diabetes, the patient underwent several examinations, among which a contrast-enhanced CT scan, which showed the presence of multiple bilobar hypervascular liver lesions. The nature of this lesion was not sure, hemangiomas or metastasis, and also a lesion of approximately 17 millimeters hypervascular was described in the pancreatic tail. So the patient underwent afterwards an MRI with liver-specific contrast enhancement, which showed again multiple liver lesions, which were considered as liver metastasis, suspicious for neuroendocrine nature. So the patient completed the diagnostic workup with an ultrasound endoscopy plus fine needle aspirate of the pancreatic lesion, and the diagnosis was a neuroendocrine tumor G2 with a Ki67 of 6%. She then underwent a 68 gallium PET, and both the pancreatic lesion and all the liver lesions showed a positive radiotracer uptake, whereas at the FDG PET, only one liver lesion, the largest one located in the 6th segment, showed a pathological hypermetabolism. So at this point, we discussed the case within our dedicated MDT. So we have a 75-year-old patient with a neuroendocrine tumor of the pancreatic tail measuring less than 2 centimeters, G2, with multiple bilobar liver metastasis. All the lesions are positive at the 68 gallium PET, and only one liver lesion shows a significant FDG uptake. So as treatment at this point, we proposed surgical resection. So in February 2020, the patient underwent distal pancreatectomy with splenectomy, metastasectomy of the largest liver lesion in the 6th segment, and cholecystectomy with a laparoscopic approach. At the final histological examination, we had a PANET G2 with a Ki67 of 10%, staged as PD1, as the maximum tumor size was 15 millimeters, and 0, and the liver lesion was confirmed as a neuroendocrine liver metastasis with a Ki67 again of 10%. So after surgery, we discussed again the case within our MDT, And we proposed to the patient postoperative treatment with somatostatin analog and also transarterial chemoembolization of the right liver lobe, as most of liver metastases were located in this part of the liver. So the patient started treatment with lanreotide, and then she had 2 TACE procedures. You can see here the pre-TACE MRI with multiple lesions, which are mainly located in the right liver. You can see it here in the video. So she had 2 procedures in July and September 2020. And then in December, she had a new CT scan, which showed a good response of the liver lesions that had been treated with TACE. But approximately 3 months after, the patient underwent a 68 gallium PET MRI, which showed a liver progression in terms of number of liver lesions, but also in terms of size of lesions that were already present. So the case was discussed again within the MDT, and at this point, peptide receptor radionuclide therapy was proposed to the patient. She underwent PRRT with lutetium 4 cycles between March 2021 and March 2022, and she had a good response on the liver. You can see here the 68 gallium PET MRI after treatment with a significantly lower liver tumor burden as compared to the 68 gallium PET MRI before treatment, here below. So after PRRT, the patient continued treatment with lanreotide, and in October 2022, so approximately 6 months after the end of PRRT, she underwent a new MRI, which showed the progression of a single liver lesion located in the left liver, this one here, measuring 37 millimeters as compared to 15 millimeters at the previous imaging. So a local regional treatment was proposed to the patient, and she underwent a TACE with selective catheterization of the left hepatic artery, targeting this lesion located in the left liver lobe. So here you have the pre-TACE CT scan, which shows the presence of this 4 centimeter hypervascular lesion in the left liver. And here you have the post-TACE CT scan, which shows a good response to the local regional treatment. So afterwards, the patient continued treatment with SSA, but again, 4 months later, she had a further progression in the lesion located in the left liver lobe. You can see it here. It now measures approximately 6 centimeters, and it has also some necrosis inside. So at this point, the case was discussed again, and we proposed another kind of local regional treatment to manage the disease, which was surgical resection. So the patient started the preoperative evaluation, but at this point we had an unexpected finding, because at blood tests we found hypokalemia associated with a severe metabolic alkalosis, and this finding was associated with very high levels of cortisol and ACTH in blood, also at the test after administration of dexamethasone on the evening before, and they were associated also with significantly increased urinary cortisol levels. At the abdominal CT scan, there was a further progression of the known left liver lesion, 8 centimeters now. So this condition was considered as an ACTH-dependent Cushing syndrome from an ectopic origin related to this large neuroendocrine liver metastasis. So the patient started a treatment with a steroidogenesis inhibitor and also with cortisone acetate. And once her clinical conditions was stabilized, she repeated the preoperative evaluation. She had another CT scan, which showed the known liver lesion in the left liver further increase, 8/7 centimeters. And afterwards, so July 2023, she underwent surgery and had a left liver lobectomy with a tangential gastric resection with a laparoscopic approach. At final histology, 2 localization of well-differentiated net with high proliferative index were found. The largest lesion had a Ki67 of 50%, whereas the smallest one had a Ki67 of 60–65%, and a minimal and focal ACTH positivity was observed. The initial histological samples from the first surgery were also revised, and actually an ACTH positivity was reported also on those samples. So after surgery, the patient continued treatment with somatostatin analog, and restaging after 3 months was indicated. At this restaging, unfortunately, there was a liver progression, both in terms of number of lesions and also size of lesions that were already present, and also lung metastasis appeared. So at this point, chemotherapy was proposed to the patient with capecitabine associated with temozolomide. So the patient started chemotherapy in November 2023. She continued chemotherapy for 3 cycles, but then she had a massive progression. You can see here the CT scan with almost all the liver occupied by liver metastasis. So a completely different tumor burden as compared to the previous imaging, and also progression of lung disease. So at this point, a chemotherapy shift was proposed by our MDT to cisplatin plus etoposide, but unfortunately, the general conditions of the patient began to deteriorate with the onset of jaundice, hyperammonemia, respiratory failure related to pneumonia, and so considered the general conditions, the disease burden, and the progression, best supportive care was chosen. And the patient passed away in April 2024, almost 5 years after diagnosis. So thank you all for your attention.
Thanks, Valentina. This was brilliant and very interesting case. This is what we see. So how many MDTs did you have on this one patient? I didn't count them, but there were quite a few.
Yeah, a lot. I think at least 7 or 8.
So, and this is almost like a chronic disease going over many years. So thank you very much. Please go on, because some of you are already sending in patients via the webinar chat, but you can also put questions in and we will ask them at the end. And thanks, Julia and Nicola, you're already trying to answer some of the questions here. So let me now introduce again Professor Thor Halfdanarson from famous Mayo Clinic in the United States. He will now give his views of the oncologist based on this case we've just seen. Thank you very much.
Thank you very much for the opportunity to participate. So let me see if I can share my screen here. So hang on a second. I'm going to make sure we have this in the presentation mode. Are you actually not sure if you're seeing this in presentation mode? Let me just try this again. So give me just a second. My apologies. So I'm not the most technically skilled. Now we should be seeing this. Are you seeing my slides?
Yes, and if you go to full screen.
Full screen it, and then we should be good. So I don't think I will ever learn
there.
There we go. And are we in presenter mode, or?
Yeah, you can swap presenter view. Yes, perfect.
Perfect. So ultimately, I'll get this. Keep in mind, I'm a medical oncologist. My world is pretty simple. So thank you to Dr. Andreasi and Dr. Pazio for the presentation. I think actually Dr. Andreasi really beautifully illustrated the dynamic nature of pancreatic NETs over time. And that is something that many people don't really fully realize. So here are my disclosures. So let's move on to systemic therapy. Why do we even need systemic therapy? So we know that up to 50% of patients still present with metastatic disease. That's work by Dr. Alay and others. And a lot of patients will later develop metastases. And the goals are different. Where the goals can be to improve symptoms of tumor bulk, improve symptoms of functional tumors, to improve or at least try to maintain quality of life. So that's the symptom side of it. But the other side of it is to control tumor growth. So ultimately to prolong survival, to prevent the complications, and maybe in some situations try to downstage to a more manageable size so things can be surgically resected. But not all treatments control both tumors and symptoms. Keep that in mind. So how do we, in terms of controlling the functional syndromes, so most pancreatic nets are non-functional, and they stay non-functional for most for their lifetime in most cases. And as you know, insulinoma, gastrinoma are the most common functional NETs, can be associated with MEN1, but often are not. And the important thing that this case illustrated was a change in functionality for something that seemed to be non-functional, that all of a sudden learned how to produce ACTH. So we're seeing more and more of this, and they can go from functional of producing one hormone to another hormone, or even go from being functional to non-functional and the other way around. So it's very fascinating. And so the control of functional PNETs truly is a multidisciplinary project. So with surgery, with catheter-based therapy, with somatostatin analogs, and even radiotherapy. We actually recently treated someone with refractory hypoglycemia with SBRT to the liver with outstanding and durable results. So here are things that work. So we have the somatostatin analogs. We have level 1 data to back that up. And it seems like delaying the start doesn't impair overall survival. We have everolimus that controls tumors, but doesn't do much for symptoms, with the exception of maybe hypoglycemia. In insulinoma, we have sunitinib that controls tumors, but doesn't do much for symptoms, but really only approved for pancreatic NETs and isn't really all that effective. We have chemotherapy, works great for pancreatic NETs, but not so great for small bowel neuroendocrine tumors. And then we have radioligand therapy like lutetium-177 dotatate that works for all 3 grades and different origins of the tumor. So quickly to remind you of the 2 prospective trials that looked at the somatostatin analogs, or SSAs. So we have PROMET on the left, we have CLARINET on the right. And as you can see, looking at the median time to progression, both trials were positive, prolonged the time to progression in the case of PROMET, and prolonged progression-free survival in the case of CLARINET. Keep in mind the differences in the placebo arm there, 6 months in PROMET, 18 months in CLARINET. This just speaks to the different patient populations enrolled on these 2 trials, but both show the same. These drugs are effective. And we're just talking tumor control, not symptom control. And we know they're super effective there. So I'll go quickly through the RADIANT trials. We have the RADIANT 2, RADIANT 3, and RADIANT 4. So RADIANT 2 was technically a negative trial in patients with functional small bowel NETs with carcinoid syndromes, mostly small bowel, and randomization between everolimus and placebo. Patients were on triatide. It showed trend towards improved outcomes, but did not meet significance. Then we have RADIANT 3, showed that everolimus is effective in pancreatic NETs, and then RADIANT 4 showing everolimus has activity in non-functional lung NETs and GI NETs. Then we have the kinase inhibitors. So sunitinib was shown to be superior to placebo in patients with pancreatic NETs. Surufatinib has data from China, hasn't been approved, at least not in the US by the FDA, but promising data. We have cabozantinib in a small phase 2 trial, and we'll get into that a little bit more here. We have lenvatinib in the TALENT trial, showed impressive objective response rates and very reasonable, quite impressive progression-free survival, not as much as I would have expected with that response rate. And then axitinib and pazopanib may have activity, but don't seem to be going anywhere. Well, then we have cabozantinib. So this is it was published by the New England Journal this fall and presented at ESMO this year and last. So fairly simple trial, patients with progressive NETs after prior therapy, grade 1, grade 2, and grade 3, pancreas, small bowel, and lung primaries. Excuse me. They all had to be progressing within 12 months and have received at least 2 lines of prior therapy, including SSAs. Randomized in 2-to-1 fashion to placebo versus cabozantinib, so 2/3 got cabo. There was crossover at progression, and the primary endpoint was PFS. Well, the primary endpoint, and I'm just showing you the pancreatic cohort, was certainly met. 14 months almost compared to 4.4 months for placebo. Overall survival, not surprisingly, was not changed, possibly because of the crossover that diluted the OS benefit out. So that's that. So let's talk about CAPE-10 chemotherapy that was used in the case. So this is a number of retrospective studies, and they are ranked in the order of how large they were. So most patients up front by Dr. Mauro Chivas, and then dropping down as the studies got smaller. But see here that the response rates are typically between 30 and 50 and even 70%. This is very active therapy, but we haven't really had level 1 data until we got ECOG 2211. So this was a smallish prospective randomized phase 2 study. Patients randomized between K-TEM versus temozolomide alone. Primary endpoint was PFS. It met its endpoint being the K-TEM being superior to temozolomide on the interim analysis. And as you look at the overall survival, not significant differences. And here you look at the radiographic responses. So K-TEM was better at almost 40% versus almost 34% for temozolomide, but that wasn't statistically significant. So K-TEM seems to be better, but temozolomide certainly has activity on its own. Moving on to PRT, I'm going to go quickly through this because I know that we have another speaker who's going to talk about this. So just quickly how PRT works. So we need the target, we need something that binds to the target, we need something that kills tumors, and we need a glue that keeps this all together. We inject it IV, it sticks to the tumor cells like 2 pieces of Velcro or 2 pieces of magnets, delivers radioactive delivers radiation to the tumor cell and kills them that way. And we really only have lutetium-177 approved. So we had NATTR-1 that all of you are familiar with, a randomization, patients progressing on a standard dose octreotide, randomized to PRT or double dose octreotide. And there was not crossover, but 36% later had PRT. Very, very positive study. Look at the PFS for the PRT arm, 28.4 months. Not difference in overall survival, not statistically significant, but certainly a trend. The NATTR-R, this is a retrospective, very well done, rigorously done retrospective study looking at PRT in pancreatic NETs, objective response rate of 40.3% with PFS of almost 25 months and overall survival of 41 months. But look at the differences here if you look at patients who got chemotherapy versus no chemotherapy before. So chemotherapy before definitely predicted worse outcomes, not surprising. So ocular random study, I'll quickly go through, so essentially showing lutetium was better than sunitinib, so we'll skip through that quickly. And this is the way I think about therapy for advanced pancreatic NETs. So think about this resection indicated, or is it even possible? Is regional therapy appropriate? Here we need a multidisciplinary tumor board. Yes, systemic therapy is indicated. Then I think to myself, is debulking needed? If debulking is needed, well, capecitabine temozolomide is reasonable. Well, so actually is PRT. If not, no debulking is needed, symptom control and tumor stabilization, well, somatostatin analogs may be appropriate alone. Well, if you need both, you give both. So, and then first-line PRT for higher grade tumors, as was done in the NATTR-2 study, which I'll show you in a little bit. So at progression, after first-line therapy, you really just go through the options you have. If you didn't give K-TEM before, you give it now. If you didn't give PRT before, well, you can do it now. Is it better than K-TEM? Don't know. We have Alliance trial testing that. We have everolimus. We have multi-kinase inhibitors, sunitinib, and possibly cabozantinib. We'll maybe find out from the FDA early next year. And then we have clinical trials. Ultimately, we're going to see progression, but you continue the SSAs if there's a functional syndrome. But at progression, you just run through all of your options again. You use whatever you haven't used before. So that's pretty straightforward. We still have a number of good options. Well, what about chemotherapy in grade 3 NETs? Let's look at objective response rates for K-TEM, FOLFOX, and platinum etoposide. You see that the K-TEM, FOLFOX are sort of the same. The PE, not quite as good, but this is all low quality evidence. If you look at the PFS, you see it actually might favor K-TEM, but well, again, retrospective studies, but you see that the PFS of platinum etoposide is actually lower. It could be just worse patient population, and the side effects are higher. So platinum etoposide seems to be sort of the least favorable option there. Well, how do I do therapy for G3 neuroendocrine neoplasms? So you look at the differentiation. If it's a well-differentiated, you treat it like you would treat grade 1 and grade 2 for most parts. You sort of just run through the options that you have, PRT, K-TEM, even somatostatin analogs. And then if you don't really know the differentiation, well, if they are behaving in an indolent way, just treat them like grade 1 or grade 2 and see what happens. If they are kind of sort of behaving badly, you might want to do this a little bit differently. And if they treat them with more aggressive cytotoxic chemotherapy. And if they are grade 3 neuroendocrine carcinomas, poorly differentiated, well, you could treat some of them with milder chemotherapy, but most of them will probably be fast-growing, need urgent interventions with platinum etoposide or irinotecan, platinum FOLFIRINOX, or even FOLFOX or FOLFIRI, which is also how I would treat the highly proliferative neuroendocrine carcinomas. So that, I think, is sort of a whirlwind approach of my take on systemic therapy for neuroendocrine tumors. So I'll try to go into the chat and ask and answer questions as they come.
Thank you very much. Impressive talk. A lot of information, and probably too many information for surgeons. But we can understand how is difficult, how is complex this disease, and probably is also the beauty of manage this patient and the satisfaction from to manage this patient to decide together. I have a question I will do at the end regarding the need of the bulking surgery, who decide if it's needed or not. So we will discuss about this later. And now it's time to hear about the perspective from the nuclear physician. So it's a great pleasure to introduce Professor Valentina Ambrosini, who is a nuclear physician here in Italy, in Bologna, and one of the most experts in the field of neuroendocrine tumor. So, please, Valentina, the floor is yours.
Thank you. Thank you, Stefano, for your introduction. I will just try to share my screen. Hope you can see everything. Curiously stopped. Okay. Okay, so now after hearing everything on the oncological side, let's move to nuclear medicine. The point is that the introduction of PET-CT mainly completely changed the view that we have on the possibility to biologically characterize the tumor non-invasively. Especially, we can have data on the biological features of the tumor on the whole tumor burden. The main advantage of PET-CT is probably can be summarized by the fact that it has a very wide field of view. Basically, we acquire scans from the base of the skull to the first portion of the legs, but maybe we can also get full whole body imaging from the vertex to the including the feet. And we have an array of different radiopharmaceuticals that we can use to assess the biological features of the tumor, mainly the SST PET-CT, that can provide us with data both on the lesions that express the somatostatin receptor, but also information about the PRT eligibility. And then we have mostly the FDG that can depict the presence of heterogeneity and therefore identify undifferentiated clones that can run, let's say, the outcome of the patient. Mostly we use to characterize neuroendocrine tumor, we use SST PET-CT. The guidelines that indicate when it's useful are summarized in the SNMI and ENM practice guidelines and also in the ESMO guidelines. And they all state that SST PET-CT has an indication in the staging, in the localization of the tumor and its spread before surgery, for the selection of patients eligible for PRT, and also in the post-PRT evaluation to serve as a new baseline to plan further treatments. We have several different radiopharmaceuticals approved, mostly labeled with 68 gallium, DOTA-8, DOTA-TOC, and DOTA-NOC. And also we have EMA approved. We also have copper labeled compound. They are all agonists of the somatostatin receptor. And we can also use them for 2 additional situations according to appropriate use criteria. One of them is the situation in which we have a mass that is suggestive of NET, but is not amenable to biopsy. And the other setting that is maybe more controversial is the presence of a biochemical evidence of symptoms of NET without evidence on CT and without pre-histological diagnosis of NET, so in the suspicion of the NET lesion. The SST PET-CT entered the diagnostic flow chart because it has a very high accuracy in the detection of even very small neuroendocrine tumor lesions, both at the primary site and at metastatic sites. There is an extensive literature supporting its role in the detection of well-differentiated tumor lesions with a higher accuracy as compared to conventional imaging and to PET-CT with other radiotracers. In the pictures shown here, you can see a very tiny pancreatic localization that was missed by other diagnostic procedure, a very small metastatic liver site, and also bone metastasis that can be evident on the PET images, even when morphological changes on CT are not apparent yet. The procedure has also a very high accuracy in detecting the primary tumor site with a combined detection rate of 56% across a meta-analysis including 12 studies. And as you see also by the case presented by Dr. Andreasi, the pancreatic neuroendocrine tumors show mostly metastasis in the liver and the abdominal nodes. And among extra-abdominal metastases, the bone are often presented. Of course, when we look at SST PET-CT images, we have to be aware of potential false positive, especially at sites of inflammation and infection, including also any site that is studied too soon after any interventional procedure. But also have to remember that there is an array of tumors that are non-neuroendocrine by nature, but they do express somatostatin receptors. So the presence of an uptake does not necessarily mean that it's a location of a neuroendocrine tumor. Among other false positive, we have to correctly interpret the presence of hemangiomas that do not have to be wrongly interpreted as potential sites of disease. Accessory spleens, detection of accessory spleen is particularly challenging when they are, for example, attached to the lower side of the diaphragm after a splenectomy, or in cases in which they are intrapancreatic and there is actually no way to discriminate it from a NET lesion based on the SST PET-CT and lone features. We have to consider that the biodistribution at liver level is present with the SST analogs, and it's usually diffuse and maybe dishomogeneous. And also we have to consider that the disease itself can differentiate over the course of the disease. And for every time you ask a nuclear medicine physician to assess the response to treatment, you have to provide a baseline scan for comparison. The tracer availability after cold somatostatin analogs treatment has to be taken also in consideration. This is a very recent study portraying what we experience every day, meaning that the treatment with SSA can lower the background at liver level. And you see the SUV max values for the liver change after the second scan, in which somatostatin analogs are administered close to the performance of the PET-CT. And how shall we improve the liver lesions detection? We can have different approaches. One is to change the radiopharmaceutical. For example, there is a new radiopharmaceutical labeled with 18-fluorine, octreotide. It's fluorine IF-OC is an analog of the somatostatin receptor, but is labeled with fluorine. And exploiting the different positron ranges with respect to 68 gallium, you can see that the image quality is much better, especially at the liver level. You see that the background in the liver is highly readable as compared to the usual 68 gallium dotatate scan, and allows us to depict more lesions. And another approach is to move to an antagonist of the somatostatin receptor. There are many radiopharmaceuticals that have been studied recently, and just to give you an idea of how different the images can turn out, in this paper by Leo, published in the European Journal of Nuclear Medicine this year, the gallium DOTA LM3 is here compared with 68 gallium dotatate. It's striking that the background is very much lower, and it allows the detection of a higher number of liver lesions. Another approach is actually to change the technology of the PET-CT. There are many new advances in the technologies aspect of the PET-CT tomograph, especially the long axial field of view PET-CT. That has a striking higher accuracy in lesion detection. This is the case from our center, scanned with a 194 centimeter Lafov PET-CT, in which a very tiny lesion that was evident on MRI of 5 millimeters showed a very intense uptake on the gallium DOTA PET-CT scan. Of course, when we talk about neuroendocrine tumor, we have to talk about the FDG PET-CT. The indication to FDG PET-CT has been debated over many years for several reasons, but mainly accounting the fact that FDG can provide data of the undifferentiated tumor clones that can be present at first diagnosis, but most often become apparent over the course of the disease. Several expert consensus have been published on the most appropriate setting in which to perform FDG, because we know for a fact that local practices varies widely in the way FDG is indicated by MDT discussion. Probably one of the leading key to FDG imaging would be to consider the presence, irrespective of grade, of a mismatch with diagnostic CT and SST PET-CT. So lesions that are evident on CT and do not show avidity on SST PET-CT should anyway be challenged with the FDG PET-CT. And in general, we can use it in any case of higher G2 or G3 net in neck. And the issue before PRT is certainly one that needs to be addressed, since it's not performed in every center, although it may provide indication on the mismatch. In fact, when we interpret FDG and PET-CT imaging, we should refer to the component of lesions that present different results on the both scans. We actually have different kind of scores that can be used and have been proposed in the literature. However, from a practical point of view, I think that this CARFIS classification is very relevant because it depicts only 3 stages, 3 grades, one in which FDG is negative, one in which all the lesions show gallium DOTA peptides positivity, and one or more FDG positive lesion that is, however, especially matched with the gallium DOTA results. And in the C3, on the contrary, there is a spatial mismatch between gallium DOTA peptides and FDG. And this CARFIS classification can better stratify patients in terms of progression-free survival much better than the grading. But do we still have to count lesions? Because nowadays the PET-CT systems also allow us to have a quantification of the tumor volume. So we can quantify the tumor volume that expresses somatostatin receptor, the one that has FDG avidity, and also we can follow the suggestion of Chan and colleagues that actually measure the discordant tumor volume, the volume that's the sum of the volumes that have FDG positivity but is negative on the gallium DOTA peptides, that shows that can differentiate the patients in different class of survival. Of course, when we move from the 2D to 3D measurement, we have to define new cutoff values for defining progression or partial response. By mathematical definition, of course, this is an issue that we have to face. And currently, there are no standardized ways on how to quantify the volume. And of course, talking about the role of nuclear medicine, we have to talk about theranostics. So we use PET-CT before PRT to find patients eligible of a better response. Currently, the EMA approved treatment with the lutetium dotatate in GAPNet in Europe, although we know that different countries in Europe also use a PRT in somatostatin receptor expressing other primary tumor sites. And still, there are several questions that are not standardized over the centers that do perform PRT, especially in the use of FDG before initiating PRT itself. The interim assessment that is variably performed among different local practices, and the procedure itself for interim assessment is different, SPECT-CT, PET-CT, diagnostic CT, and also how to assess response. The guideline recommend the RACIST, but we know that they face several difficulties in the assessment of the neuroendocrine tumor response. So probably the best way is to integrate the diagnostic with PET-CT parameters, and also when to assess response is quite variable, some from 3 to 12 months, depending on the guideline and local practices. The results of the NETTER-1 and 2 studies have been already presented by the previous speaker. I just wanted to quickly show you the result of the Stättner study that shows that the pancreatic NET shows a good response, although lower than the one expected for the ilean NET. And of course, the guidelines from ESMO indicating PRT as second or third line treatment for PANNET are challenged by new possibility. First of all, the possibility to use PRT as a neoadjuvant treatment or for a treatment, and then the issue of how to assess response. The treatment is feasible for neuroendocrine tumor patients because, as mentioned by the previous speaker, there are no other treatment options in the relapsing patient. It can be considered, although the data available so far indicate that we expect a better response in patients who showed a good response to the first course PRT, and that those that stayed in a good response for sufficient time, generally considered 12 months. In the setting of neoadjuvant, of course, the cytoreduction that can be obtained by PRT is appealing to especially the surgeon, especially the NETTER-2 study showed that there is a very good response to PRT in the setting of G2 and G3 patients at initial diagnosis. And in this same study by Stefano, already mentioned by Nicola, the treatment of neoadjuvant PRT facilitated surgical resection, obtaining a partial response in 58% of cases with overall lower toxicity. And in the setting of PRT, certainly new areas of research will be to define the role of alpha therapy. There are several papers in the literature portraying very good results with 212 lead dotatate, and also with the antagonist DOTA-LM3 labeled with 177 lutetium. We have new radiopharmaceuticals that can have either new isotope labeling, like with the alpha therapy, or new targets like the DOTA-LM3 exploiting the antagonist versus the agonist. And certainly the interest in theranostics is increasing, but still we need training programs that build the new nuclear medicine profession that has two faces, the diagnostic and the therapeutic side. And thank you for your attention.
Well, thank you very much, Valentina. This was a brilliant presentation. And I think we as surgeons, we need to know about theranostics. This is the future. And you could show us what will be on the market, what is already there. But we will discuss this later on. Just one reminder that I've seen, you talked about false negatives, and I remember one case in Innsbruck that was resected, which was then an accessory spleen within the pancreas. So this ended up with a fistula. So always be aware of that, and we could discuss, of course, doing biopsies, etc. So thank you very much. We will take questions at the end. And now let me introduce the last speaker of tonight. Very, very impressive speaker, Professor Julie Halley. She's amazing, really sensible, telling us that the knife is not always the best option in these kind of patients. And I'm really looking forward to Julie's talk. Thanks, Julie, for joining us.
All right. Thank you very much for your kind introduction, Stefan. I'm going to get these slides going. If I can just get a thumbs up that this is working, we'll get moving.
Yep.
Good. Excellent. So I have the difficult task of speaking last and not repeating what everybody else has said before me, but I'll try to give you sort of the surgical perspective and really focusing on the case that we talked about at the beginning and trying to understand sort of what data and considerations come into my mind if I'm sitting at an MDT discussing this patient. So the first thing I noticed is that this pancreatic neuroendocrine tumor initially was measured at 17 millimeter, and so would be considered by some as a small, non-functional, sporadic pancreas neuroendocrine tumor. And those who might have heard me speak before or read things on this topic might have heard that it's okay to observe small pancreas neuroendocrine tumor that are non-functional and sporadic when they're less than 2 centimeters. And if I were in person, I would be looking at Dr. Stättner right now because we've had heated debates about this. But then I'm pretty sure that some people have thought about, well, you know, this was small and there were metastases and look at what happened after. You know, if you observe those small lesions, you're going to miss some patients that needed surgery and needed treatment. And so I just wanted to talk about this for just a minute. That there are non-functional sporadic peanuts less than 2 centimeters that can be monitored. But here's selection, like in a lot of instances, is really key. So those small peanuts less than 2 centimeters that can be observed have to meet all the criteria that we have on this list. So they have to be homogeneous, do not distort the pancreatic gland, no obstruction of the duct, so no dilation of the main pancreatic duct, no calcification, and no distant disease. When all those criteria are met, I think we have now prospective data indicating that it is safe to monitor those patients. However, if any of those conditions is not met, there are small tumors that are aggressive, and I think this is a good example of that. So in this instance, on the CT, you can see the tumor was heterogeneous. It was distorting the gland. There was infiltration beyond the pancreatic parenchyma, and there was distant disease. So everything that does not meet the criteria on the prior slide, consider surgery, that's for sure. Not all small peanuts are benign behavior. So with that being said, my second thought when I read through the case was the importance of the role of the surgeon. I know I'm speaking to an audience that will support me in this, but I think it's important to state. So this is a survey that we just ran with Dr. Partelli and Dr. Stättner, looking at our new collaborative about surgery for neuroendocrine tumors that has aptly been named CutNets. And we asked 27 centers that are dedicated neuroendocrine surgical centers in Europe and the Americas about like what is each person on the multidisciplinary team doing at what stage of treatment. And you can see here, the first column is us surgeons. And so about 92% of surgeons will be involved, and 92% of centers, surgeons are involved in the initial assessment and the workup, and in about 80% also in surveillance and monitoring of those patients. And even in a third of centers, surgeons are also involved in the delivery of somatostatin analogs. That's certainly the case in our center. So we have an important role to play. We're often the sort of front door or first point of contact for those patients with the health system and with medical therapy. So we need to really own that as surgeons and then work with everybody else to get good plans for patients. And among those centers, there's also, again, speaking of the importance of multidisciplinary clinics and teams, we have 85% of centers that have NETs dedicated. So specifically NETs tumor boards. I'm not talking about one NETs in the GI tumor board that also speaks about pancreas, but really neuroendocrine dedicated NDTs. And the vast majority will meet weekly or bi-weekly, so more than once a month. And you can see here, again, speaking to Professor Fazio's remarks at the beginning, that there's a wide array of people that are involved in those MDTs, and we need all those people involved. And the other here included anesthesiologists, cardiologists, heart surgeons, interventional radiologists, etc. So again, just to stress the importance of this and how specialized centers are set out to do this, because this is a tough job. And as a surgeon, one of the things we look at when we think about PNETs is how do we evaluate which ones are at high risk? That's how we'll make this assessment of risk and benefits and balance things out to decide in which ones it's worth offering surgery or not, and in which ones systemic therapy may play more of a role. And in systemic therapy, I include all radioligand therapy, so PRT. This particular case, things that I noticed, it's a higher grade, so it's a G2, 6% Ki-67. It's not super high, but it's still in this intermediate category. It's not very low grade like the G1s. There's multifocal liver metastases, so sort of higher tumor burden. We have to consider that's a bit more aggressive and more tumor to treat. And then, as was mentioned, importantly, there's sort of dual avidity of both SSTR and FDG on the functional imaging, so the PET scans, and that plays an important role in assessing what we're going to do for the patient, including surgery. Why? So this is data showing progression-free survival in patients by primary tumor site that had hepatic cytoreduction at a Mayo Clinic. Dr. Alpnerson is one of the authors on this. And it just shows that some tumors do better than others. So small intestine does better than pancreas, which you see here. And we can talk about this at the end. The role of cytoreduction in pancreas is probably very different in small intestine, especially for non-functional tumors. It's also important to consider grade. As I mentioned, the higher grades don't do as well as the lower grades. And so you need to know the grade when you're assessing somebody for surgery. One of the tough cases, not necessarily this one, but tough cases when we face G3 pancreatic neuroendocrine tumors. So well-differentiated neuroendocrine tumors that have a higher Ki-67. In general, the ones that are below 50% will fare better after surgery, and those are the ones that we'll select for surgery. We can also look at some genetic alterations, specifically DAX and ATRX. And the first person who taught me about that was Dr. Alpnerson. Those patients that have mutant DAX, ATRX have a higher risk of recurrence and lower overall survival after surgery. And so we need to pause when we see those in terms of deciding on surgery. And then a very quick word about functional imaging, because we talked about this. So this is how I see this as a surgeon. What we're used to is the FDG PET, and that means that higher uptake equals bowel tumor, bad prognosis. In neuroendocrine, the SSTR PETs with higher uptake is better prognosis because the tumors are better differentiated. And Dr. Ambrosini showed us like one way of combining everything. Another way of combining this is this dual PET CT score that was developed by one of our former medical oncology fellows in Toronto, who's now in Sydney, Dr. Chan. And basically you looked at what's the spectrum between being no avidity on FDG and high avidity on SSTR PET versus high avidity on FDG and low avidity on SSTR PET, and then created this net PET score that we have been using in our practice, but is being validated and assessed in prospective studies right now. So that's one tool that we can use. Ultimately, you said a little pink panther on that. The first slide for this section is because we're looking for clues that will give us an idea of what will work best for those patients. And we have to put all those clues together. There is not one answer on one item we need to find to decide what to do. It's a combination of everything. This is the way that I've thought about this. And in general, I would say everything on this side of the screen, you want to consider surgery. Other factors play in here, but you want to consider surgery. Everything on the other side, so when you're talking higher Ki-67 over 55%, or ATRX, DAX mutant, you want to think twice about it. Like steel may not heal in those cases, and you have to pause for a second. And I wanted to quickly talk about heterogeneity because I think it played a lot in this case. We talked a lot about heterogeneity of tumors. It was in the chat as well. And really, I looked at what's the definition of homogeneous and heterogeneous. So homogeneous can actually be a mix of different things, right? No one tumor is exactly just one thing. It just means that everything is mixed in a very uniform way such that you cannot see the different component and you cannot pick them apart. When you have heterogeneity is because you have different components, but they're separate, they're spread out, and you can actually pick them apart. It'll like think about the soup that's like very well mixed and a pizza. So there's lots of Italians here. I had to put a pizza on a slide. On the pizza, you have different components. Each slice will be different, but you can actually pick them apart, right? I did that as a kid. There were pieces of pizza I didn't like. I give them to my sister and I ate what I wanted. And this is a little bit what we see here, right? The tumor is not homogeneous. There was heterogeneity with that FDG avid lesion versus the other liver metastases, and that played into the decision. So it's important to also have that assessment because it makes a big difference. Not everything will be treated the same, even within one patient. And just finally, quickly speaking to the role of surgery, the most important message I think here is that in stage 4 pancreatic neuroendocrine tumors, surgery is not curative. We're not get those patients rid of their disease. And so we're not thinking the way we think about colorectal liver metastases, for example. You have to put on our neuroendocrine thinking cap and see things differently. The goals of therapy are really controlling the tumor volume, the endocrine activity, and then local regional complications just from tumors sitting there, which can impact quality of life. I see neuroendocrine, and some people talked about, you want to continue to run, etc. Like it's really a marathon that we're running with the patients to bring them as fast as forward as possible with the tumor. And I think surgery can help spare other therapies. So delay the time when they're going to need more systemic therapy or prolong the time when systemic therapy will be effective. So I think by combining surgery with other therapies, sometimes that other therapy will work for longer. And I know I don't have prospective data on this for all the oncologists on the webinar. So I'm going to ask the oncologists to just cover their ears now and not listen to what I'm saying, because I know you don't like it. But with long-acting somatostatin analogs, what the Clarinet trial and PROMID as well in non-PNET has showed is when there is less tumor volume in the liver, there's actually better progression-free survival. So my surgeon mind thinks that if I can reduce the hepatic tumor volume, maybe they will work for longer and they will work better for patients. In terms of the primary tumor resection, this is data out of Italy where they looked at when the liver disease or the metastatic disease is unresectable, there can still be value in resecting the primary tumor. They looked at those that were resected for distal pancreatectomy and splenectomy versus, yes, the unresectable ones, but importantly, the ones that were resectable and declined resection. And I think that this is really key. There's a signal here. Similarly, the patients that had primary tumor resection tended to have better outcomes after radioligand therapy delivered following surgery. Again, speaking to this idea, if you have better control of the tumor volume, you may get better outcomes of other therapies. Quickly saying, when we talk to those patients, it's important they understand that the question is not whether the cancer is going to come back or progress. It will happen. The question is, when will it and what can we do when it happens? The risks of those surgeries are very acceptable and well described. And so we're not putting patients at extreme risks. Even quality of life can be really good after this. It's prospective data, small cohort, but you can see that both mental and physical components of quality of life can improve after surgery. So I don't think we're hurting those patients when they're well selected is the message. Are we changing survival or biology? I don't think so. What we're doing is something different. So like sparing therapy, better controlling tumors, and potentially improving quality of life over time. And so those multidisciplinary evaluations are really key. This is our team at Sunnybrook. You don't know what you don't know. And so it's important for me to understand I don't know what Dr. Singh or Dr. Meyerhog know, and for them to understand the opposite so we can talk together. One thing I'm very passionate about is this data from Ontario a number of years ago, where 60% of patients with neuroendocrine tumor never saw a surgeon. And I think that's a really big missed opportunity because we can contribute to this. So we need to advocate in our circles to see those patients. So in summary, surgery for pancreatic neuroendocrine tumors, we have different goals. I want to acknowledge that there is a real risk of harming patients that at baseline have a long-term survival. So we have to be very thoughtful about how we pick the patients for surgery and how it fits with the other therapies that exist. Looking at the sequencing for this particular patient, I really like that timeline that Dr. Andreasi has on, because it reminds me of the different steps. And the reality is there will be sequencing and we have no idea what drives better sequencing. We have no data on this. And so I think an important point is at every step of the way, and here there were like many MDTs, as we mentioned at the beginning, go back to the MDT, reconsider all options, like everything's on the table again, think outside the box. And while thinking outside the box, just remember the key nets principle, so we don't go into like the colorectal liver mets box, let's say, and we remain focused. And I think the MDT is very important, talking to our multidisciplinary colleagues, but also talking to each other. Often there's not many surgeons doing neuroendocrine in one center, so it's good to have a network, be able to call friends. Those are all people that I've called about cases where I struggled, where I wasn't sure I wasn't making the right decision, and they've helped me, so it's good to have as well. And yeah, in the end, it's good to have friends, and don't forget to put your neuroendocrine thinking cap when you talk about those patients, because they're different.
Julie, I would listen to your talk hours and hours. Thank you very much. And thank you for putting the cherry on the top of this very beautiful webinar. We have maybe time, like 5 minutes for some discussion. Before asking a question that was made on the chat, I would like to focus on this concept of debulking. So thank you, Julie, also for the plea that only 60% of patients are seen by surgeon. So my question is to the oncologist and particularly to Tor, who decide if debulking is needed, the oncologist or the surgeon? Because you showed the slides and this was like, if it's needed, by who? In my view, it's the oncologist to decide if it's needed and the surgeon decide if it's feasible. What do you think?
Oh, great question. So I think I look at it in two different ways. So look at it as a debulking for symptom control, and we now have data from Mayo, more than 500 patients that surgical debulking results in very, very durable and often complete symptom control. But we wouldn't really, the surgeons wouldn't really know that because these patients are coming through medical oncology. So ultimately, we may suggest this to the surgeons, we may get the patients on the tumor board, but ultimately it's a team that decides. And same thing with survival. I totally agree with Julie. I do not think that these are curative intent procedures, but they can, what I sometimes tell my patients, we may set the clock back by maybe a number of years. No one really knows how much, and we really need better data. But it's a joint decision.
Nicola, what do you think about this?
I think that any therapeutic strategy, especially debulking, should be discussed collegially, and it should be discussed reporting the potential advantages and the risks, the disadvantages by the surgeon, first of all. So the surgeon should express an opinion regarding the feasibility of an absolute debulking, first of all, if it's possible or not. Sometimes it could be possible at 90%, and the rest can be approached by means of interventional radiology, for example. We should know this upfront, and we should have an idea about this scenario in terms of quality of life, in terms of potential investment in terms of prognosis. But at the same time, we have to discuss at the same level the alternative therapies that we have. And after this, we have to compare among us, and finally with the patient, as the attitude of the patient is one of the elements that should be considered. It doesn't mean that the patients should choose, of course, but it's important to realize this, okay? As sometimes, of course, even some emotional decision can be made due, for example, on the chronological age of the patient, for example, but we should be very objective to judge everything. I think that the final decision is really collegial here.
Thank you. A question for Valentina from the audience. What is the role of PET-FDG? So I would ask you, should perform PET-FDG in all patients with metastatic disease? Yes or no? And which are the patients with localized disease who can benefit of a dual tracer PET?
Okay, so first of all, patients that show mismatched lesions between diagnostic CT and somatostatin receptor PET-CT. So if I have any patients, any grade, any primary that shows FDG negativity in a lesion that is evidence on CT, should undergo FDG. In the other setting, probably we still have to rely on grade, although sometimes we know that grading has been assessed even years before the date in which we consider doing FDG. So we will go for higher grade G2, G3, and NEC, especially in cases in which we want to have information about prognosis. And also, of course, it could be useful also before PRT, although we know that many local practices still do not use it. And especially one thing, if we do FDG and it's positive, we are basically almost obliged to repeat the scanning with FDG over the course of the disease to completely assess the response to any treatment we decided to undergo to indicate the patients to.
A question for Julie about the role of primary tumor resection in functioning NET, considering bilobar, so not resectable liver metastasis.
That's a tricky one. Maybe I'll answer in two parts. The first part is a politician answer that's going to diverge to something else. But I would say unresectable is in the eye of the beholder. I think no liver metastases or primary tumors in neuroendocrine should be considered unresectable until an experienced neuroendocrine surgeon has looked at it. In particular for liver mets, we don't really do anatomical resection. We enucleate, we're going for an R2 resection. So the techniques are very different. And what we're able to do with experience is very different. So always have a NET surgeon assess that before saying it's unresectable. And if it is, I think in functional pancreatic neuroendocrine tumor, it can have a role to resect the primary. Again, it depends on what is the resection. The main role to me is if you have to do a distal pancreatectomy and splenectomy, because the morbidity mortality profile is very different than a pancreatoduodenectomy, for example. I don't know why, and I don't think anybody knows why, but it seems like the primary tumor in functional pancreatic neuroendocrine tumors act as a type of a pacemaker that activates the disease. And often when you resect it, you get a good functional control, even without touching the liver metastases. I had a young 40-year-old recently who just could not get out of hospital because of hypoglycemia from an insulinoma. We were able to resect his primary 12-centimeter primary tumor in the tail of the pancreas. He has widespread, massive, unresectable liver metastases, and his blood sugars have been normal without any treatment for the past 4 months. So it's quite amazing sometimes the results you get. I'm not exactly sure what the mechanism is, but it exists. The caveat to that is I think it has to be assessed very carefully, very patient-tailored, and also with multidisciplinary discussions so that all aspects are considered and we don't hurt patients by trying to do good. But I've observed that in a number of patients.
Thank you. So
and just
yeah,
to mention, because I think there's lots of maybe learners on the call for the pancreatoduodenectomy. The problem with it is the morbidity profile that's different. So the risk benefit is different, but also if people have liver metastases that are not resected and will need liver directed therapy like embolization in the future, when we create the hepaticojejunostomy, we colonize the entire biliary tree. And so there's much higher risk of abscess and sepsis and very complicated infectious issues after liver embolization. So by doing Whipples without touching the liver for sort of palliative intents, we can compromise the ability to receive other therapies after. So it's a bit of a different thinking than when we're talking about tail of pancreas.
Great. So probably there would be many other questions and discussion, but unfortunately we are run out of time. So I will leave the podium for final remarks to my co-chair and friend Stefan.
Yeah, well, I'm always impressed of these talks. I always learn a lot. Thanks everyone for joining us and give this amazing presentations. So I think we have to ask you as presenters if you would provide us with the slides, because some of the auditorium, they asked for it. Probably last short answer, I don't know who will give it, but there was a question, a bit of discussion here about transplantation in this kind of disease, in liver-limited disease. So in my 4 years of Innsbruck, I've sent a push 2 patients for transplant, and they did it. And I think it's also important, if you have these discussions, that dedicated NET specialists are talking to the transplant guys, because they usually have no idea about NET. This is also an interesting thing. But probably one short answers, because we still have 134 attendees in the call. So who would like to give an answer to this question, transplantation? Is there an indication, a role for it?
Very quickly, and I reviewed that because I gave a talk about it a while ago for NANETs. The role is not 0, but it's very close to it, and it's very limited. Main thing is a lot of the data that people use to support transplant for NETs comes from like decades ago, when we did not have the therapies we have now, when we were not able to debulk patients safely like we are doing now. And so I think most patients that were transplanted back then and on whose outcome we look at to justify transplant would not be transplanted now. They would be debulked, they would be treated with other systemic therapies. So the role is exceedingly small. Not never, just close to never is my take.
Thank you very much, Julie. So Stefano, it's your part, last words.
I just want to thank again our speakers, because here in Europe it's now late, and on the other side of the ocean they are in the middle of a working day. So thank you very much for your time. Thank you to all the participants, because you are many participants for these rare tumors. Is very impressive number. So I hope you enjoy, but I'm sure you have enjoyed this webinar. Stefan and me with ESSO, we are organizing a course, so stay tuned, because we will give some updates in the next upcoming weeks. And again, thank ESSO and thanks ITM for the support. I'm sure we'll organize another webinar soon. Thank you again, all the speakers, and have a good night.